Chapter 3: Patient Assessment and Communication. Introduction. As radiographers, we must learn to assess the needs of the patient and formulate a plan of care that best fits the individual. So we're going to do this through assessment, critical thinking, problem solving, therapeutic communication, and patient education. Personal understanding. Technologists must be people-oriented. It is a hands-on profession. It is critical to be able to interact with a diverse population. Your communication skills will determine the patient's opinion. Interactive skills can make patients' visit very pleasant. Personal needs. As a healthcare worker, you need to have the want to help others. You need to be good with working with people. You need that drive for making a difference. Think critically and demonstrate creativity and achieving results. The health illness continuum. All persons seek to maintain a high level of well-being. Health can be defined as the status of an organism functioning without any evidence of disease or disfigurement. Unfortunately, a perfect state of health is rarely achieved. Therefore, health is seen as on a continuum. Stress we'll discuss here in a little bit as well. There's a lot of different various forms, and then our basic needs. So this is just showing you an image of kind of what we just talked about, your continuum or lifespan of health. So basic human needs. This is actually taken from Maslow's basic hierarchy of needs. And so number 1 is your physiological needs. Number 2, safety and security. Number 3, love and belonging. 4, self-esteem and esteem of others. And 5 is self-actualization. So this is the image of Maslow's hierarchy of needs. You see a few extras on here. Helpful hint, you might see this on a test. So it is good to know both of these images or both of these figures, and both will work for the test. Basic needs. Understand that the patient is in a possible altered state of consciousness. Again, they go into a hospital that is an unfamiliar environment. They're scared because they don't know their state of their health, and they may, again, be just in a different mindset at that time. It's not like when they come in to a building otherwise. They do not want to be in care of health professionals, and we see that a lot with adults, and we'll discuss that as we kind of go through. And they fear what you're going to tell them. You know, it's kind of, we always think it's going to be cancer. We always think we're going to die. And so that does become a huge concern for our patients. It causes patients to be rude, impatient, etc. So again, it's not that the person is normally rude. It might just be the circumstance of, again, a lot of times they go to admission and then they sit and wait. They've already been to the doctor. Now they're getting x-rays. They might have had to wait for a lab. So even just the situation itself is sometimes stressful and causes a change in your patient. Patients and imaging. Anxiety, maybe stressed. And again, that's due to their being unwell. Communication issues, aggressive behavior, silence and withdrawn. And we'll talk about those a little bit more as we go through here as well. They may not, again, be their same bubbly self that they normally might be. And so they're not going to maybe want to disclose all their information. We as radiographers, we must determine a person's state of health and be able to work around it. Again, there's going to be questions that we have to ask, and there's going to be things that we really need to know in order to give the best care that we can. Patient dignity. Illness and trauma can alter a patient's being. It may cause altered behavior. You must meet level 1 to proceed to higher levels. Use dignity and respect when working with patients. Patients are put into awkward situations, so the utmost care is needed to ensure patient dignity. These are some really great examples of what we see in the hospital. Again, do you think this patient walking down the hall? Yeah, it's funny. But do you think that's do you think he just goes around the house like that or in his neighborhood? And now we're walking him across halls with his rear showing, and how many other patients is he going to see in those other rooms? Or how many other people is he going to pass? So again, you know, men don't exactly like wearing a gown. It's like a little dress that they're not really accustomed to already. So it's in a very uncomfortable situation. The one to your right, you know, this is an NG tube, and we'll talk about those in chapters ahead. So, again, an uncomfortable situation. So, do your best to give your patient dignity. It's kind of like him in the wheelchair. Without that sheet there, his stuff may just be out hanging out. So, a sheet just kind of covers it up, and you might not want to leave him in an area that is a bunch of people around. He's not used to having an NG tube in, and we'll kind of talk about that as we go through. Critical thinking. The hallmark of an excellent radiographer is the ability to achieve a positive diagnostic or treatment result in a timely, effective manner while meeting the unique needs of the individual patient. Cognition, effect, didactic, and psychomotor, which we'll discuss as we go through. But these are all things that learning requires: cognitive, affective, and psychomotor skills. Terminology. So, domains of teaching. So, cognitive includes various levels of thought, knowledge, understanding, reason, and judgment. Psychomotor includes behaviors involving physical actions, neuromuscular manipulations, and coordination. Affective includes behaviors guided by feeling and emotions that are influenced by interest, attitudes, values, and beliefs. Critical thinking requires the ability to interpret, analyze, evaluate, infer, explain, and reflect. Modes of thinking. Recall. Knowledge of scientific facts that you can recall at a moment's notice while the patient's. Habit. You will develop habits that make for the efficient practice of learned skills. Inquiry. Using the skills of recall and habit along with higher mode of thinking. Creativity. It is used to solve individual problems and to prevent causing the patient discomfort or pain. Knowing how one thinks. Introspective is required. Think while you're actually thinking. So, critical thinking takes time and practice. Make a habit of higher level thinking. Recall learned classroom material into practice in the clinical setting is required. Problem solving and patient assessment. Every patient and every diagnostic procedure presents problems, ranging from simple to complex. The student radiographer must decide how to perform the assessment quickly, efficiently, and as comfortable as possible for the patient. We're going to do this through data collection, data analysis, implementation, and evaluation. Data collection. There are two types: subjective and objective. So with subjective, anything that the patient or significant other who accompanies the patient says in regards to their care. Objective is anything you see, you hear, feel, or read on the patient's charts or information given by another healthcare worker. You need both objective and subjective data. So objective data is perceived by senses. It can be seen, heard, or felt. And again, subjective is perceived only by the patient. You can't tell them how they feel. So it's the patient's emotions, their experiences, and are not pertained through senses. Never discard anything the patient actually says. So mark it all down. Analysis. The part of assessment integrates all segments of critical thinking. Once you have all your data collected, you must decide how you will achieve your goal to perform the exam with the quality images, patient comfort, and efficiency. This method requires demand recall. Planning and implementation. Planning requires the use of all modes of thinking. Theoretical concepts learned from the classroom instruction are recalled. Implementation of the plan depends on the patient's problems and the needs for assistance to achieve the desired goal safely. Creativity is a requirement to achieve the set goal in same cases. So really, what's it saying? For us, this would be make a plan. A patient comes in for a hand x-ray. So again, you need to think, okay, well, I'm going to need this size cassette, or I need to set up, if you're digital, this type of equipment. I need to move my tube around. I'm going to obviously be taking 3 views. And so you kind of set up the room to make it easy, so when he comes in, or her, they're able to sit down, take the few images, and move quickly forward. Evaluation. Each patient care situation differs in some way or another. As a student, you will observe many approaches to a successful exam. And with that being said, you will also see ways not to handle a situation. One must never cease learning from the patient, regardless of how many years of experience he or she possesses. Each patient care situation differs in some way from all others encountered. Therefore, all patient care experiences are learning experiences. And I always say, you're going to do a whole lot of chest x-rays. And I know it's the very first lesson, so you're not even sure how to do a chest x-ray yet. But when you get in the clinical setting, you will, and you do a lot of chest. And so every person is different, every patient is different. Every time you do a chest x-ray, it will be different. And so always take all of that and keep it as a learning experience from each time. Culture diversity in patient care. Culture is defined as the socially inherited characteristics of a group of people that are transmitted from one generation to the next. The patient's culture and ethnicity will play a major role in assessing the patient. Their culture, sociological, psychological, physiological, and biological. Culture and ethnic diversity are a part of the radiographer's assessment and plan for care. And this will come into effect. You'll find out very quickly. Each patient is different. Each culture is different. And so it is good to know that, some cultures, they don't like to be touched. Most actually understand that it needs to be done in order to have these exams, but they may not believe in taking off certain products or certain garments. And as long as you can work around it, it's okay. But there are going to be times that you're going to have to tell them they're going to have to take it off in order to get a good assessment or a good x-ray. Patient expectations. The patient also has expectations of the healthcare worker. The patient expects professionals to be concerned, clean, well-groomed, professional, and deliver quality patient care. So again, even just the fact that our requirements for our students to wear scrubs that are not wrinkled is meaning that you look professional and that you should be cleaned and you should be groomed so that they have that appearance of the professional qualities that they expect. Communication. You're going to hear me talk and talk and talk about communication all the way throughout these 21 months, because it is the most important thing that as a technologist we can do and make the best situation for our patient and for us. So all members of the healthcare team must learn to communicate clearly and therapeutically with patients. Any problem of communication, whether major or minor, has an impact on the patient's healthcare. To become a successful communicator, you must develop skills: listening, observing, speaking, writing. It is essential in providing quality patient care, and there's really two different types, and we're going to talk about these individually. So verbal and non-verbal communication. Verbal communication. This is messages sent using words. It's used to establish an open relationship between you and the patient. Vocabulary, clarity of voice, and organization of sentences must be at the appropriate level for the patient. You should occur face-to-face when possible. Be polite and pay attention to how patient is taking you. Culture and individual differences may affect their perception. Be careful not to patronize or demean them. Just because a patient is old doesn't mean they need to be spoken to as a child. They are very aware. They're not just because they're an older patient, they're not mentally altered. So they're going to take it as demeaning them. So make sure that if it's a kid, you talk to them as if they're a kid. If it's an adult, talk to them as if they're an adult. Humor. Humor can help relax and open up the conversation. So humor is a great way to interact with a patient, but there are a lot of humor that you have to avoid. And it's funny, being in a hospital, I have heard all kinds of things that you would think, oh no, I would never, looking at this list, think that I would ever say anything like that. It sometimes happens. So avoid culture slurs, age professionals, sex, diseases, ability of health, or disabilities. So it's even like, oh, well, taking an x-ray and you might have been doing it for years and go, oh, well, it's my first time. They stress out. They start to think, oh my gosh, this is their first time. It doesn't matter. Age, if you make age relation jokes, they could think that, on both ends, that you're young or that you're old and that your abilities could shift. Self-depicting humor, again, it could be good, but it needs to be used in the right tense. Laughter is always good medicine. Nonverbal communication. There is more to communicate than the spoken word. The unspoken or nonverbal aspects of communication can be defined as all stimuli other than the spoken word involved in communication. So, nonverbal communication functions in the following ways. It may repeat or stress the spoken word, so maybe like a head nod, you know. It may accent the spoken word. It may regulate the spoken word. It may substitute for verbal communication. Gender factors. The radiographer must be aware that the manner of communication will vary depending on the sex of the patient. The possibility of a patient requesting a technologist of the opposite gender. The radiographer must also be sensitive to the issue of gender in his or her professional interactions with coworkers and avoid sexual innuendos. A lot of physicians now, if they're with a female and they're going to have to do, an exam of something that may need to be seen with her being, completely naked, they will have a female come in so that way there is no question and somebody else witnesses their interaction with that patient. And we're seeing that as well. Now, if they ask for somebody of the opposite gender, X-ray and the X-ray technologists are such a small group that if it's in the middle of the night, you may be on call and it's just you, and they're going to have to get over the fact that it's just going to be you. But what you might be able to do is get someone from a different department just to come in to make them feel better. And it's usually more male and coming into a female. Again, they're going to be in a gown. They're going to be really exposed. We see that more than with a male asking for another male patient or technologist. Other factors that affect communication. Paralanguage has to do with sounds of speech rather than content. A patient who has difficulty standing, sit the patient and make them comfortable. If the patient has difficulty hearing, speak louder, speak to the patient. So there's a lot of ways that we can kind of adjust depending on the type of patient that we have. So again, we're going to talk about some of these here. Paralanguage, body language, touch, appearance, hygiene, physical presence, and your visual contact. Paralanguage. So this is the music of language. It's the cadence, the rhythm, the speech. It's your, things are perceived differently if you say something with, "Are you okay?" Might sound like it's a question. It's kind of how it's perceived. So pitch has a big deal with that. Tone, rate of speech, volume, accent, stress, pauses, quality of voice. So ask productive questions. There's times that a pause is needed. That way they can kind of come in and know that that's where they're supposed to be answering or so forth. Body language. Be cautious to avoid giving confusing signals. Positively, it can be used to increase quantity and quality of communication. Look at your patient and show interest in what they are saying. Smile and use a friendly tone. The reason I use this image here that you see to the right of your screen with her hands crossed, I had a technologist that I worked with for many years, very friendly, but she would stand in the halls and she would cross her arms, and it was perceived that she didn't want to be there, that she was upset about something. So doctors didn't want to deal with her for that reason. She wasn't upset. She was just standing there, and she would stand there with her arms crossed. So again, body language that's a defensive move to keep your arms crossed. So kind of keep that in mind when you're standing around. Negative cues can also help with history. So avoid standing far away with your arms crossed, just kind of like we talked about. It can be taken as repulsed by the patient, and it can be taken defensively. Touch. There are 3 types. Emotional support, so that's just, gentle tap on the back. For emphasis, specifies instructions. And for palpation, which is for positioning. Responds well to touch. Most patients will. Considered acceptable with proper conversation. Conveys understanding, empathy, and care. Support for assistance helps provide assurance of the care. So if you notice they're in a wheelchair, help them get up. Put an arm underneath them so that you're helping them move over to the X-ray unit. So again, there's so much that we do with our patients to help them stand, because they are going to rely on us completely for the assistance to move. Professional appearance helps the patients feel comfortable and confident of professionalism, gains patients' trust, and abide by the dress code. Believe me, I will know if you were not. It's always interesting because our professional appearance is scrubs. And so, I might be out at the Dollar General and someone will see me in scrubs and start saying, oh, well, I've got this itch. It's like, whoa, 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 that's not what I do. But they always look at you in that professional manner and think, oh, well, you're a nurse or you're a doctor, or, oh, hey, I've been sick with this, and try to tell you their symptoms even outside of work. Personal hygiene. Unkept individuals prompt suspicion of unprofessional behavior. Hair, nails, teeth should all be kept neat and clean. So again, our policy is your nails will stay short. They will not be painted. Your hair will be pulled back if it's past your shoulders. Body odor. If they can't stand to be around you, they're gonna have a negative reaction or a negative experience with you. So again, deodorant is a must. You must take baths. Patients can be allergic to perfumes, so you are not allowed to wear perfume in the hospital. It causes negative reaction. Patients, and it's kind of like, I'm sure you've all been in the elevator after a woman with a ton of perfume comes out. I mean, it burns your nose. So kind of same scenario there. Patients are not going to have a positive reaction if they do not want to be close to you. Now, on the other side, if they don't smell good, we pretend that it is a positive experience. So we'll kind of talk about that as we go through as well. Physical presence. Posture is important. It's perceived as confidence and self-esteem. So I'm sure you've heard fake it till you make it. It's kind of the same. Go in, be confident in your abilities, even if it is your day one. Act like you know exactly what you're doing, that you're supposed to be there, and that way it's taken as you are in control. Facial expressions are vital. Importance of instructions and questions. Negative and positive reinforcement of actions and statements. Visual contact helps ensure that questions, instructions, and other information is being understood. Inspection of condition can be critical when looking at blood pressure and allergic reactions produced symptoms. Establishing communication guidelines. Many relationships between the radiographer and the patient are brief, and it is essential to make the best use of your time. Establishing guidelines for interaction is essential. And I'm going to be talking shortly about how you should introduce yourself and so forth. So we'll talk about that. So the first thing you're always going to do, introduce yourself. Give an explanation of what the exam is. Give an explanation of what is expected of the patient and what the patient can expect from the imaging staff. Approaching a patient. So again, first thing you need to do at least is introduce yourself. It's kind of like, before you get me naked, at least let me know who you are. And again, that's what you're going to be doing. You're going to go ask your patient to undress, take everything off, and put on this little tiny gown. So the next step you need to do is verify your patient's identity. Make sure that you have the correct patient. And we do that by asking date of birth, is the normal way. So, what's your name? And then give me your date of birth. Explain the examination that is to be done. Obtain a brief history. Some departments have forms present for this, and some other forms of prerequisite forms may be required. You need to have good communication. Therapeutic communication techniques. Establishing guidelines, reducing distance, listening, using silence, responding to the underlying message, restating the main idea, reflecting the main idea, seeking and providing clarification, making observation, exploring, validating, and focusing. Non-therapeutic communication techniques. Judgmental statements, cliché statements, false reassurance. Again, in healthcare, we can't say everything's going to be okay if it's not. And so there are some things that we have to watch out for. Defending, changing the subject, giving advice, subjective interpretation, disagreeing, probing, or demanding an explanation, again, are all just non-therapeutic for your patient. Obtaining a patient history. The goal of a patient history is to obtain necessary information to perform a safe and comfortable examination. Obtaining the information accurately demands sensitivity and critical thinking on the radiographer's part. During the history-taking process, the radiographer must convey a professional image to ensure the patient's confidence. Patient assessment. Objective evaluation and determination of the status of a patient. One of the initial communication skills is through the assessment of the patient's chart. You should look at the patient's history and their indications. The Sacred Seven. So this is going to be localization, chronology, quality, severity, onset, aggravating factors, associated manifestations. Our job is to get a more focused history specific to the procedure being performed. And again, in order for our radiologist to make a good assessment of the image that we give them, they need to know as much background information as they possibly can, and how much it hurts, stuff like that, so that they can make a informed diagnosis. Localization. Determination of a precise area. Carefully word questions and use a light touch to palpate area if necessary. Patients give consent to have the exam and what is needed to get that exam. Patients can refuse at any point and the exam should be terminated. So it doesn't matter if you've already started and they're in the middle of an exam or you're almost done. If they refuse, you have to terminate at that point. Use of touch, we kind of mentioned already. So emphasis, again, specifies instruction or location. Palpation is positioning and helps with history taking. Pain can be non-localized, so, oh, I hurt everywhere. But make sure to note an attempt to the radiologist and try to, again, get that information as much as you can of, well, where does it hurt worst if possible, so that is addressed to the radiologist. Chronologically, time element of the history. So duration, frequency, and course. Describe this in days, minutes, hours, etc. The radiologist may deprive information from this, so avoid actual dates. And you're going to hear all kinds of things of, oh, it's been hurting for years. So again, how many days, not really the date instead. Quality. Characteristic of symptoms. Use specific terms like acute, which is sudden onset, or chronic, which is prolonged. Use descriptors like burning, throbbing, dull, sharp, crushing, etc. Probing questions can help with accuracy. Severity. Describes intensity, quantity, or extensiveness of problem. Examples: intensity of pain, how many lumps, extent of burning. Onset. Involves patients explaining what they were doing when the condition began. It can help to determine if its predictable events preceded reoccurrence. Aggravating factors. You see down here on your right of your screen, that seems to be my aggravating factor all the time. But circumstances that produce the problem or intensity. It should be well defined, anything that aggravates, alleviates, or modifies. So if they say, well, if I lift it up, it doesn't hurt as bad. So again, something that you would need to note and put into their history. Associated manifestations. Determining whether other symptoms accompany the chief complaint. This helps determine if it's related or a separate condition. Clinical history. Information available regarding a patient's condition. Traditionally, it contains data on localization, quality, quantity, chronology, setting, aggravating, and associated manifestations. Extract as much information as you possibly can. It's really like an interview, and we'll kind of talk about that as we go through. Our role. History taking is one of the most important diagnostic tools. Possessing good history skills is essential. It helps to acquire clinical information that contributes to the diagnostic process. It allows for more specific details that will be relayed to the radiologist. You get to play a role in that healing process. You can help reduce patients' fears. You can become part of the art of healing and process when taking patients' history. Listen to what the patient says and show attentiveness, and that can provide them with a sense of caring. Patient education. A patient who comes to the imaging department has a right to expect that he or she will be instructed as to the exam. A detailed description of the procedure, a description of the purpose of the exam, appropriate amount of time, an explanation of any unusual equipment, Follow-up care results after procedure is complete, and if the patient questions the exam, do not begin until the problem is resolved. Inpatients. Someone who has been admitted to the hospital for diagnostic studies or treatment. Gain the patient's confidence. Past experiences can leave a negative effect on patient. They must be transported to the radiology department either by wheelchair or stretcher. So you're never going to let your inpatient come down and just walk. Even if they say, oh, I can walk, I can walk. Have them sit in a wheelchair. And if, again, they're not even able to get up, then you would need to have a stretcher. Always be aware that patients are watching and listening. I can't stress this enough, that while you're walking through the halls, they see you. If someone's been sitting in the waiting room for a long period of time, they've seen you go back and forth. So stop and tell them, hey, it's going to be a few more minutes. I've had this emergency come up. I'll get to you as soon as I can. Always watch what you're saying. I know that you step into another room to process your cassettes or to look at your images or to transfer paperwork, and what you say to even fellow technologists can be heard. And they may not even know what you're talking about. It might be an x-ray of somebody else, and you go, oh my gosh, the patient's going to think you're talking about them. Outpatients. These are someone who has come for diagnostic testing or treatment but does not occupy a bed. Expect to be seen immediately, even when it's not possible, scheduled or not. Delays are inevitable due to previous patient taking longer than we thought, extra projections ordered, uncooperative patients, more serious patients being seen ahead of an outpatient. Check on the patient and apologize for delays. Again, keep them up to date on status. Be aware they are waiting and acknowledge them. Treat all patients the same no matter their status. Again, depending on the size of your department, you may only have one x-ray room. Well, if an emergency comes in or a stat comes in, you're going to have to go take care of that other patient before getting your outpatient. Because again, they're walkie-talkie. They're there just for maybe a pre-op or something like that. So it's not life-threatening where the others may be. Patient's family. They can be helpful and they could be not as helpful. So these people must also receive attention no matter if they are here for an out or an inpatient. Be courteous to these visitors. They are concerned and may ask you a whole lot of questions. Do not diagnose the patient to them or their family. It is illegal. So I don't care how broken it looks and how for positive it's broken. You can never say it's broken. You can only say, I think, I don't know, I'm not positive. Your radiologist will let you know. Your doctor will know. So again, refer them to speak to their doctor. We are not the expert, so we cannot diagnose. Make everyone feel as comfortable and relaxed as you possibly can. Understanding various types of patients. There's going to be seriously ill patients, visually impaired, speech and hearing impaired, non-English speaking, mentally impaired, and substance abusers. Understanding conditions can help meet your patient's needs. Seriously ill, traumatized. Be prepared that day one, when you step into the hospital, you're going to see patients that are possibly on tubes. You're going to see head wounds. You know, they're there for a reason. So they're not going to all be walkie-talkie. You may act differently because they may be acting differently because of pain, stress, or anxiety. Try to communicate with the patient and determine their coherence level. Try to figure out the nature of the illness, disease, or trauma, and it can alter the individual's ability to cooperate. Work quickly and effectively, but still communicate. And I don't care if the patient is laying there and you don't think they know anything at all. They may look like they're knocked out completely. They may still understand you. You don't know. So don't say things that might be taken wrong. Treat them like a person, not like a number. Watch for visual cues of change. There are, we do injections for contrast studies. And so if something starts to change, then we can sense during the exam that, they might pass out, they might be having an allergic reaction. So check their breathing, look at their vital signs, etc. Use common sense. Patient's cooperation is a key factor in producing quality radiographs. And really for us, if we see someone about to pass out, it is our job to make sure they don't hit the floor or they hit it a lot less harder. So we're supposed to actually put ourselves in the position to try to catch them as much as we can, to assist them down to the floor. Visually impaired. Try and gain the patient's confidence immediately. Give clear instructions and describe what is happening. Gentle touch establishes someone is near, if needed. Continually use communication to assist this type of person. Something else about visually impaired patients that I had no idea until you work with some, that they don't like to be grabbed, even though you're going to be walking with them. They don't want you to grab underneath their arm and pull them. They want to actually grab your arm and then you guide them. And that just gives them a little bit more reassurance that they're still in control. Speech and hearing impaired. Use writing for communication if you can't get loud enough for them to hear. Do not insult their intelligence by simplifying terminology. Demonstration always works, so you can actually show them what you want. Have your patient copy your actions to make sure they understand. And then sign language is an option if you know it or if you have an interpreter there. Non-English speaking, use touch, facial expressions, and demonstration. Use basic words. If you know some of their language, try to use it. Don't worry about pronunciation or accent, because believe me, I have a Texas accent. I do try to use some of my Spanish sometimes, but again, I know it's not perfect and it's not very great, but they at least can maybe do what I'm asking them to do. If you have an interpreter, have them come in if needed. We are in Texas. There will be a lot of non-English speaking patients. So the most that we come in common with is probably Spanish. But other than that, again, we're a diverse population in the Dallas-Denton area. So you may come across all different types of patients. Mentally impaired. Immobilization techniques and interaction skills are required. Use strong yet reassuring tone of voice. Conversation during prep and exam help the patient stay calm and aware that you're trying to help. Substance abusers. These are pretty difficult to work with at times. They're not entirely aware of what they are doing and may need to be restrained. Assess what they can do. Work quickly. Observe them at all times and get help if needed, or wait until the effects have worn off. So my biggest suggestion would be, if they're thrashing around or something, have ER, give them their medication, and let it wear in before you go in. That way they're at a little bit more rested state. I would never do a patient alone that is on some type of substance, and it doesn't matter if they are intoxicated or if you think it's something more severe. Their demeanor can change at any moment. They may come in smiling and happy, and then the next thing you know, they're aggressive. So never do this patient by yourself if you can avoid it. Mobile and surgical examinations. These patients are too sick or cannot be moved. They begin by calling patient's name. You still identify yourself and explain the procedure. Never assume they do not understand comments. Using caring tone and gentle touch. Clear the room, but let them know it will only be brief. Visitors appreciate courtesy and thoughtfulness. Interacting with the terminally ill patient. Death is inevitable. I've had students go in on day one and someone code on them. So it can happen. I hope it doesn't. But you are going into a field that you will see death. Obtain assistance when you think that the patient is coding. It's better to be safe than sorry. Some patients are kept in closed awareness and lack acceptance. In suspicious awareness, the patient will look for clues of their condition. If you mutual pretense, when everyone knows and tries to avoid any conflicts. Elizabeth Kubler-Ross stages. I'm not sure if many of you know or have heard of this one. Denial and isolation. So initial reaction, allow the patient time to accept. Anger comes next. It comes with realization. Try to accommodate them. Bargaining focuses on hopes and prayers. Be supportive. Depression. Remission ends. They give praise and let them share their feelings. Preparatory depression comes with realization of death and is wanted. Touch and silence are needed. And then acceptance. Total lack of feeling in the final stage. As a student, you must learn how to deal with dying, and you need to realize what type of what stage your patient really is in. Loss and grief. So again, stage 1, we just kind of said this: denial, anger, bargaining, depression, and then acceptance. Patients' rights related to end of life issues. The public wishes to make their own determination in the matter was resolved when the Patient Self-Determination Act, or PSDA, was made law in 1990. You can have an advance directive. They are legal documents that are formulated by a competent person that provides written information concerning the patient's desire if they are unable to make the decision on their own. This is also called a living will. It's a directive to physician. Durable power of attorney for healthcare, or DPAHC, or DNR, or a no code. What does that mean? It means if they are on this list and they have decided that they do not want to be resuscitated, and you bring this inpatient down, you need to know that, because if you start to do CPR on this patient, you will be held liable. It doesn't matter if it's a slight where they could have a quality of life afterward. If they are DNR, if they are no code, you cannot help. You cannot assist that person. Terminally ill patients have some control over their deaths. Advance directives, like I mentioned, still a legal document by a living adult to provide guidance to healthcare officials if the individual should become unable to make their own decision, aka living will, durable power of attorney. So example we just kind of mentioned is our DNR. Patient autonomy. Ability and right of the patient to make independent decisions regarding their medical care. You must abide by the patient's decision. I like to give these out every once in a while. You can read these on your own. This is just something from past students. So kind of helpful ideas or their experiences that they had when they were coming through the program. And be prepared when I have the end slides. They can be anything meaning the end. And it is the medical field, so I am a little bit, just be prepared. The end. The end. So I try to have a story sometimes with these, but this is just in the old way of electrocution. Thanks.